I welcome you to this session being organized as a part of the ToxMaster Class India advanced training program, specially to encourage the youngsters to, with the basic objective of prime objective, I can say, to uh, know, apply for the American Board of Toxicology certification exam, followed by becoming one of the diplomats of American Board of Toxicology, which we consider as one of the gold class in toxicology field. And I'm happy that I am a part of this ongoing training program. And today I'll be delivering my talk on toxic responses of the kidney. And before we proceed for the topic, the basic objective, I told you that the basic objective of this entire training program is to encourage the youngsters to take their profession in the field of toxicology. And to in the field of toxicology, if you want to continue, the primary objective is that you need to be a certified professional. And one of the world's leading board is the American Board of Toxicology, followed by European uh, regulatory toxicologist by Royal Society of Biology. And subsequently, there are many regulatory agencies or the societies or all the associations. But if you see, the primary objective of all these associations is that everyone expects the toxicologist to be on par with their regular update of knowledge. That is the prime objective compared to other fields. Those who are planning to settle in the field of toxicology, we anticipate or we expect that they should be on par with the knowledge. There should be a continuous update of the knowledge pertaining to this particular field. And I'm also happy that there is a lot of candidates, the applicants who are enrolled in this training program, that they are appearing for the ABT. And the ABT I have qualified in 2011, followed by recertified in 16, then in 21, and now in 25. The process is ongoing, and whether you see the ERT or ABT, we always the body always looks for your continuous knowledge update about each and everything. And not only the continuous update, we also expect the candidate to have a strong basic foundations. It's not like that you have, there is always, whenever I meet with the youngster, they always say there is a lot of gap in the availability of information on par with other countries. But if you see the foundation, what we anticipate from a person who wishes to work or who wishes to settle in the field of toxicology is the subject, the knowledge foundation. So if you see the qualification or the syllabus for the course of the ABT, please keep in mind that most of the questions, they are going to test your basic understanding of the damage that is happening inside a particular organ or a system, and they are not going to assess you that you have what on par with how far you are you are knowing something latest or something recent. No, we always want you to know the basic damage that is happening inside. Am I audible, right?
Yes, sir. You are audible.
Okay, fine. If there is any issue, you can just you can drop me in the group, right?
Yes,
So
sure, sir.
with these few words, I'll be in between also. I'll be updating you about what are the various issues or various things that you need to keep in mind to clear the ABT in at single attempt, and what exactly will be the question paper and all those things I'll be covering. So as a part of this training program, I have been assigned to take up two important systems. The syllabus is very vast, but I have been assigned to take up two important systems, that is toxic responses of the kidney today. I'll be covering the whole the renal system, followed by the toxic responses of the respiratory system subsequently in the mid of the July. And I was all these last 30 to 45 days I was monitoring. Most of my colleagues voluntarily they are spending their valuable time and enlightening the youngsters. So let me just start with the toxic responses of the kidney. And the session I have divided into 120 minutes. In these 120 minutes, I'll be covering the basics. I told you that we need to know what exactly is the physiology, then we need to know what exactly is the pathology. Then when you know physiology, you can understand pathology. When you understand pathology, then you can understand what is pharmacology. When you have a basic idea of pharmacology, then you can appreciate what is toxicology and how a particular organ is responds to a particular damage by a chemical, whether the chemical could be a drug or a poison or even any substance that produces the damage. So I have divided the topic into these areas. So if I start the topic about the toxic responses of the kidney, yeah, whenever I say the kidney's pivotal role in homeostasis, so the word whenever we start the word kidney, the functions of the kidney it comes into your mind is the excretion of waste, that is 40% of the filtered urea is excreted, electrolyte balance it maintains, acid base balance it maintains, secrete hormones like renin and erythropoietin, and activate vitamin D3 to 1,2,5 dihydroxy vitamin D3. So the kidneys play a pivotal role in maintaining all these as a body's internal balance known as homeostasis, and primarily the kidney assists the body in these five objectives of excretion of waste, electrolyte balance, acid base balance, and secrete hormones like renin and erythropoietin and activate vitamin D3 to 1,2,5 dihydroxy vitamin D3. Let us see how it works and how exactly it plays a critical role in this. So if you see the endocrine functions of the kidney, beyond its excretory and regulatory roles, the kidney also participates in endocrine functions, that is renin synthesis, crucial for blood pressure regulation, erythropoietin production stimulates red blood cell production, vitamin D3 activates vitamin D for calcium balance. So consequently, any toxic insult to the kidney can disrupt these essential functions, leading to profound and widespread effects on the entire body metabolism. So basically, as a toxicologist, some of you are involved in drug development, some of you are involved in kinetics, some of you are involved in dynamics, some of you are involved in pesticide developments or cosmetics or anything. Ultimately, any substance that needs to be excreted has to move on through the kidney, and the topics what I have taken, respiratory system and the renal system, both have the highest exposure to these exogenous substances, because 90% or more than 70% of the drugs are chemical, they need to get eliminated from the renal system, and that is the reason why when any chemical is being eliminated from a particular system, what is the chance the damage that particular chemical produces on that system, and what is the impact that is going to have on whether it is a limited or a widespread effects on the entire body's metabolism, is something which we need to look after. Let us just move on that how the kidney is doing all these five functions. First we will try to understand that how these functions are being done by the kidney, so that it will be easy for us to understand where exactly the damage can happen and how the damage is being repaired, and really for a decision making in toxicology or risk assessment, how that particular part we can assess. Now if you see, I told you that first I told you that this it performs a function, then I told you that these are the places where the damage can occur. But before a damage can occur, we will also see that how the vulnerability or defense mechanisms will be there. While kidney possesses inherent detoxification mechanisms, a significant functional reserve and remarkable regenerative capacities, severe toxic challenges can overwhelm these defense systems, culminating in kidney injury. So please remember that every organ inside the body is designed in such a neat and clean manner that the existing systems in each system, each organ itself will cater to the needs or the repairs or the regenerations. However, we only say that a particular chemical has damaged the organ only when the defense mechanism the vulnerabilities are overwhelming the defense. That is, the damage is overwhelming the defense mechanism. So ultimately, a normal kidney performing these 5 functions, if it is exposed to a particular chemical, despite of its remarkable regenerative capacities, still the defense mechanism is unable to protect its, from the damage. Then we call that the the kidneys start showing the toxic responses. So the progression to renal failure can result in permanent damage, often necessitating chronic dialysis or in severe cases kidney transplantation. But that is an end stage. We are not going into that particular part. But now initially we will start with what exactly is the response and how each chemical is going to produce response, and how these responses are being overcome by these kidneys. So if you want to just keep it in a simple way, this mnemonics is a wet bed, that is acid base balance maintaining, water balance maintaining, electrolyte balance, toxic removal, blood pressure control, erythropoietin making, and D vitamin metabolism. So anything that damage kidney, we always say it results in the patient to enter into a make a bed wet. Now I told you that why the kidney is uniquely vulnerable. The kidney's unique physiological attributes contribute significantly to its vulnerability to toxic injury, especially because of these 4 factors: the metabolic activation, active transport, toxin concentration, and high blood flow. If you just recollect your memory about the performance of the kidney, 1200 ml per minute is the renal blood flow, 650 ml per minute is the renal plasma flow, the glomerular filtration rate is 120 ml per minute, and urine excreted is approximately 1 ml per minute. So if I say renal blood flow, that is 1200 ml per minute, that accounts to be 25% of the cardiac output, or 0.5% of the body weight of any human being. On an average, if you calculate 70 kg a human being in a new way, or 50 kg an old way. So 1200 ml per minute renal blood flow, 650 ml per minute renal plasma flow, 120 ml per minute is the glomerular filtration rate, and urine almost 1 ml per minute. So massive work is being done by these 2 kidneys, and that is the reason why. And uric acid excretion and reabsorption, ion balance, that is especially sodium chloride, calcium, potassium, and toxin concentration elimination. All these, even an human, for example, if he need to consume 4.5 to 5 liter of water per day, despite of non-consumption also by that particular human being, the kidney will be in a position to ascertain that the osmolarity is being maintained inside, the ion balance is being maintained inside, and water permeability is to be preserved, and so many factors it will be taking care of. So a little bit will go slowly inside. So high blood flow, the renal cortex, the outer region of the kidney, receives an exceptionally high percentage, approximately 90% of the total renal blood flow. This disproportionate blood supply exposes the renal cortical cells to higher concentrations of blood-borne toxicants compared to other organs. So please remember that in the ABTs, most of the youngsters, they feel that the question paper may ask only about the damage that is being done or the names of the chemicals. The questions will always will be framed in on the basic fundamentals also. So if you see the kidney, I told you first the 5 functions, then followed by the vulnerabilities, and then coming to the blood supply, the cortex major portion receives 90% of the blood flow, so exposed to high percent of chemicals. Medulla receives 6 to 10% of the blood flow, and papilla receives 1 to 2% of the blood flow. But if you see the cortex, they exposed to high concentration for high period of time. So even if you see medulla and papilla, even though they are getting only 6 to 10% of the blood flow or 1 to 2% of the blood flow, but exposure to high concentration for high period of time will be very high. But overall, if you see, the damage to the cortex will be very high compared to medulla as well as papilla. So what is the factor 2 is the concentration of the toxins. So the medullary and papillary tissues located in the inner regions of the kidney are exposed to elevated luminal concentrations of toxicants for extended periods. So cortex is having high exposure percentage wise, whereas medulla and papilla is having duration, concentration for high periods of time. So this is a consequence of kidney's ability to concentrate tubular fluid and the relatively sluggish blood flow within these regions. So the flow of the blood is slow, the duration of the exposure of the chemical is high. That is why we consider the medulla and papilla are the regions where the concentration exposure duration is very high. Now, what is the third that makes the kidneys vulnerable is active transport systems. We all know that the fundamental functional unit of the kidney is nephron. Nephron is made up of the glomerular filtration apparatus, followed by PCT, then loop of Henle, then DCT, then CT, and then the ureters. If you see all these portions, not only the excretion of the uric acids or the unwanted excreta, the kidney's primary role is in reabsorption of the ions, especially sodium, potassium, chloride, calcium, and magnesium. We'll see in depth in subsequent slides. But please remember that kidney actively transports and concentrates numerous substances, including various toxicants, into the intracellular environment of tubular cells. This active accumulation can lead to high intracellular concentration of toxicants, increasing their potential for causing cellular damage. Now the fourth one is metabolic activation. So why the damage can happen? Because of the high blood flow through this particular organ. The renal cell possesses the enzymatic machinery to metabolically activate certain compounds, transforming them into more reactive and inherently toxic intermediates. Usually in the basic toxicology language we call it as lethal synthesis. Say for example, in case of liver we say parathion is converted to peroxan, malathion is converted to meloxan. The body is then in that case, even the body is trying to eliminate the chemical, but in the process of metabolism or the ion transformation, a low toxic compound is becoming highly toxic compound, so that we call it as lethal synthesis. So here also these reactive metabolites can then bind to cellular macromolecules, initiating a cascade of events leading to injury. So initially a compound is less stable, less harmful substance enter the renal cell, enzymatic action takes place, renal enzymes metabolize these compound, then reactive intermediate is formed, so a highly toxic metabolite is formed, causing cellular damage. So lethal synthesis, where we see the very commonly the organ is trying to eliminate the chemical, but in the process of metabolism the body is trying to call it as a lethal synthesis. Now before we go further, now so far we have seen that what is the function of the kidney and what is the blood flow to the kidney, and what is the why the kidney is vulnerable because of the renal blood flow, because of active ion transport, because of metabolic conversions. Now slowly let us see that what exactly is the components of the kidney and what is each component will be trying to make up before we enter into each segment. Now if you see here, the I'll also demonstrate you an animation in the subsequent slide, but for your understanding I have kept this slide in an easy manner, that the kidney is located and the kidney's major role is those 5 functions, and whenever the blood is being supplied to the kidney, you have two suppliers, afferent and efferent. The afferent size of the artery is very big because it can sustain that pressure. Efferent, that is very small, so that the flow of the blood should be slow. So if you see here from the renal artery, it enters into the nephron, that is through glomerular capsule, then glomeruli. Then please follow the numericals I have mentioned, that is 1 is the PCT, 2 is loop of Henle, 3 is DCT, and collecting duct, that is the last one. Now if you please see that the afferent arteriole that is entering is thick in size compared to the efferent arteriole that is thin in size. So the afferent arteriole is so beautifully designed, entering into the glomerular capsule, into the glomerulus. The size is so high so that the pressure that is dumped into the glomerular filtration apparatus, it is designed in such a way that the capsule that is surrounding will be having will be in a position with the epithelial cells, will be able to collect the filtered compounds, and from there it enters into the PCT. The filtrate will enter into the PCT, and then in the PCT, if you see, there is a reabsorption of the sodium ions and secretion of the creatinine, uric acid, penicillin, and so there will be the all these organelles, all these parts of the nephron. Basically, they perform three activities. One is secretion, another is reabsorption, and the third one is the diffusion. So the PCT and then the loop of Henle, we divide them into two categories. One is the ascending limb of loop of Henle, where we have a thin segment and a thick segment, and then a descending limb of a loop of Henle. But from our pathological point of view, or from the physiological or anatomical point of view, the ascending thick segment of the loop of Henle is very critical, because there we have one important component called sodium potassium 2 chloride co-transporter mechanism, which is responsible for reabsorption of sodium, potassium and 2 chloride ions at the ascending limb of the thick segment of the loop of Henle. So please remember that in the Bowman's capsule, whatever they filtrate based upon their molecular weight, that is 70% of the plasma reaching the kidney is filtered. So the glucose, amino acid, sodium ions, potassium ion, their size is so less that it gets filtered and then it PCTs. That is the reason why in the lumen, whenever these important chemicals required by the body, ions or the glucose, they are entering into the lumen, they will be reabsorbed or secreted depending upon the requirement of the body. So the sodium potassium 2 chloride that is present in the loop of Henle, which is being reabsorbed into the blood vessels. Then from there again the potassium gets leaked into the cell, and then based upon the electric potential that is created by the reabsorption of the potassium again re-enters after the thick segment of the ascending limb of loop of Henle, and because of the re-entry of potassium into the loop of Henle, magnesium and calcium are reabsorbed. So again I am repeating, in the thick segment of the loop of Henle, the sodium potassium 2 chloride transports will be there, they will be reabsorbed, and the potassium again re-enters above the segment into the lumen, and because of the electric potential, the magnesium and calcium will be reabsorbed. So if you are giving a drug which blocks the sodium potassium 2 chloride or any chemical that damages the loop of Henle's activity of sodium potassium 2 chloride, it not only prevents the reabsorption of sodium potassium and 2 chloride transports, that is these ions, it also prevents the reabsorption of magnesium and calcium, and thereby the excretion of calcium in the urine will be very high. Calciuria we call it as. So if there is a glucose is reabsorbed more in PCT, amino acids are reabsorbed more in PCT, and in the urine, whenever we go for the culture of the study of that is urine examination, if the glucose is very high, amino acids are very high, the PCT is damaged. If the calciuria is very high, so we need to think that somewhere the loop of Henle has been damaged. Then subsequently, if you see the distal convoluted tubules, this is also a place where the sodium and potassium are reabsorbed. There is no electric potential parallel like what we are seeing in the thick segment of the loop of Henle. Then here only based on the sodium and chloride ion channel gets opened and reabsorption takes place. But at the collecting duct after the DCT, if you see the three segments, that is the aldosterone acts there, the potassium secretion happens there, and the renin system, all they starts producing the aldosterone and the ADH, all they start producing the activity at the collecting duct. So overall, if you see the, I have just depicted here that nephron function. Nephron is the functional unit of the kidney. Broadly, in the last 10 minutes, I told you what is kidney and what is the parts of the kidney. But now we are going into the functional unit of the kidney, that is nephron. The nephron is having the blood supply through afferent and efferent arterioles, enters into the glomerulus, and from there PCT, then descending limb of loop of Henle, then ascending limb of loop of Henle, thin ascending segment, thick ascending segment, and then DCT, then collecting duct. So its main functions include regulating the concentration of sodium salts and water by filtering the kidney's blood, excreting any excess in the urine, and reabsorbing the necessary amounts. Please remember, excreting any excess in the urine and reabsorbing the necessary amounts. It also regulates blood pressure and volumes, controls the level of metabolites and electrolytes, and helps eliminate waste from the body. Every word is critical for the well-being of a particular living organism. Any drug that we develop, if it is having any kind of deviation or having effect any on part of the kidney, despite of its excellent effect, recovery effect on any part, then we have lot of issue in ascertaining that how we can save the drug or bring it to the market, because anything that damages the kidney, definitely the kinetic is going to get affected, and again we need to seek how best we can do. So what is the nephron help? Remove excess water, waste and other substances from your blood. Return substances like sodium, potassium or phosphorus whenever any of these runs low in your body. Now if you see the renal vasculature and glomerula, slowly I am entering. So broadly I explain into the nephron, and now slowly I am entering into the each part, and then we will see how the each part is critical and what happens when the damage happens to the each part. Am I audible, right? Am I audible,
Yes,
right?
sir.
Yeah.
Yes, sir, you're audible.
Yeah. So the next is renal vasculature. So gradually we are moving into each segment of the nephron. Till now, starting we discussed about the kidney, then cortex, medulla and papilla, and then nephron overall, and now we will go to one segment of the nephron. Now, what is renal vasculature and glomerulus? Now, blood enters the kidney via the renal artery, which subsequently branches into afferent arterioles. These arterioles supply the glomerulus, a specialized network of capillaries critical for blood filtration. Blood exits the glomerula through efferent arterioles. So, glomerulus is a complex specialized capillary bed composed of capillary endothelium, basement membrane, then epithelium podocytes. 70% of the plasma reaching is filtered here. Then after the blood exits the glomerula through efferent arterioles. Now let us see how the filtration takes place. The glomerular efferent and efferent arterioles play a crucial role in regulating the glomerular capillary pressure and the rate of plasma flow. The glomerula produces an ultrafiltrate of blood, a process governed by a delicate balance of hydrostatic and oncotic pressures as well as the ultrafiltration coefficient. So it is a sophisticated barrier where the glomerular capillary wall functions as a size and charge selective barrier, effectively restricting the passage of large macromolecules and negatively charged molecules. Toxicants that impair the integrity of this barrier can lead to conditions such as proteinuria. So the glomerular filtration made by the capillary endothelium, basement membrane, epithelium, podocytes, whenever there is a damage. So if you see, based on I told you 120 ml per minute is the glomerular filtration rate, and this rate is decreases if there is a transcapillary hydrostatic pressure and glomerular plasma flow due to increased arterial resistance, or decreased surface area available for filtration resulting from decrease in size or number of endothelial. So we will keep it in a very simple, that please remember that glomerular capillary permits a high rate of fluid filtration but provides a barrier for macromolecules, because I was using two words here. One is size selective, another is charge selective. So because I told you that not only reabsorption of glucose and amino acid, the whole ion, sodium, potassium, chloride, phosphorus, magnesium, calcium, all these things needs to be taken care by the filtration. So small molecules such as inulin, for example, molecular weight of 5500, are freely filtered. Large molecules such as albumin, where the molecular weight is 56,000 to 70,000 daltons, are restricted. Neutral or cationic molecules are filtered. anionic molecules are restricted. Again, I'm just repeating. The small molecules like inulin are freely filtered. Large molecules such as albumin are restricted. Neutral or cationic molecules are filtered. Anionic molecules are restricted. So this is about the glomerular filtration. Then let us see the next is the PCT. It is like a workhorse for the nephron. The proximal tubule, we call it as the workhorse. We divide this proximal tubule because it is very critical. And for us, whether you do drug development, whether you do clinical trial, whether you do toxicity study, anything, urine is one sample which is you will be very eager to know what is happening with the urine examination. So because the PCT, we divide the PCT into three segments, S1, S2 and S3, because it's a very large segment, and then it is having most critical work part of the nephron. So we call it as the workhorse. So the proximal tubule anatomically divided into S1, S2 and S3 segments is often referred to as workhorse of the nephron. Due to its extensive reabsorptive capacity, it reabsorbs a substantial proportion, approximately 60% 80% of the filtered solute and water. So S1 is convoluted. It's a tall brush border, well developed vacuolar lysosomal system, and extensively interdigitate with many mitochondria. So increased oxygen consumption. So usually whenever we get any kind of adverse urine examination result, the first point is that definitely there is more damage in the PCT. Then absorbs light molecular weight, proteins, amino acid, glucose. 0% of filtered glucose is excreted and bicarbonates. So S1 there is lot of oxygen consumption and absorbs the low molecular weight proteins, amino acids. S2 segment transition between the convoluted and straight, because S3 is straight, S1 is convoluted. In between S1 and S3, S2 will be there. It is a shorter brush border, fewer apical vacuoles, and principal site of organic anion and cation secretion. In the PCT, we have organic acid secretion and organic base secretion. Just like we say on this earth, we have a drugs, we classify them all as weak acids or weak bases, and in the kinetics, we see that all acidic drugs, they absorb in acidic pH. They do not, ionization. Acidic drug in acidic medium, they unionized, and acidic drug in basic medium ionized, and any drug molecule in ionized state get excreted faster. So in the PCT ST segment, S2 segment also, we have uh, important organic anionic secretion and organic cationic secretion system that is responsible for catching and secreting the important ions that are essential for the body. The last is the S3. It is straight, that is the distal portion of the PCT, well developed brush border, fewer and small lysosomes, and principal site of GSH transport. And also there is a, whenever the S3 segment is getting affected, there is increased GGT will be there. So PCT is responsible for 60 to 80% of the solute and water filtered at the glomerulus. So it reabsorbs almost 80% of the solute and water filtered at the glomerulus. And you can imagine that if any damage, if any kind of urine culture is showing some abnormal amount of glucose or amino acids, then PCT is something which we need to keep our mind. So same thing, this segment is responsible for reabsorption of essential electrolytes, amino acids, glucose, and low molecular weight proteins. Additionally, the PCT actively secretes weak organic, same thing, reabsorption electrolytes, amino acids, glucose, proteins, secretion weak organic anions, weak organic cations. So toxicant induced injury to the segment significantly compromises the kidney's ability to maintain water and solute balance. So let us see the site selective injury in the PCT. So the varied chemical biochemical characteristics of the different proximal tubule segments, including differences in the transport capacities and the enzyme activities, especially cytochrome P450, cysteine conjugate B lyase, contribute to the observed site selective injury caused by various toxicant. We'll see again which toxicant causes which damage in which segment of the kidney. But please remember that always the higher your contribution to a particular organ, the higher your significance to the a particular organ, the more will be the damage to you. So I have just depicted the another image of the PCT here, S1, S2 and S3 segments. You can see that how the S1 is convoluted, how the S2 is a transition between a convoluted and the how the the PCT works in this particular slide. Now after the PCT, now we will go to the loop of Henle. Now I told you that it is the um, most of our drugs, especially the cardiac related or the diuretics or any renal related, high chunk of our drugs are working on loop of Henle. The loop of Henle consists of thin descending and ascending limbs and a thick ascending limb, all of which are crucial for the kidney's ability to concentrate urine. So 25% of the filtered sodium reabsorbed in the loop of Henle, and 25% of the filtered potassium reabsorbed in the loop of Henle, 20% of the filtered water reabsorbed in the loop of Henle. So in the glomerular apparatus, filtrate has adequate quantity of glucose, potassium, sodium, water enters into the filtrate into the lumen of the nephron. So PCT reabsorbs 80% and followed by a loop of Henle and thin descending loop of Henle, freely permeable to water and electrolytes and urea. Thin ascending limb plus low permeability water, that is sodium chloride, is reabsorbed by passive diffusion but not urea. Thick ascending limb impermeable to water, active transport of sodium and chloride mediated by sodium potassium chloride. So most of the time, even in examinations also, they will be trying to establish your level of understanding about the function of each and every segment of the kidney. Now kidney is a very broad word. Nephron especially, what PCT does, what loop of Henle does, S1 what does in PCT, S2 and S3, and in the loop of Henle also, what is the role of sodium potassium 2 chloride and how the water is reabsorbed, and especially because of creation of sodium potassium ATPase activity, how the potassium reabsorption again re-entry into the lumen of the nephron, creating electropotential gradient and reabsorption of magnesium and calcium. Am I going too fast? Am I audible, right?
Yes, sir, you're audible.
Am I going too fast?
No, sir.
Okay.
Understand. Please proceed.
Pardon?
You can proceed further, sir.
Yeah, thank you. What is the susceptibility of loop of Henle? So the thick ascending limb is particularly susceptible because I told you the location of sodium potassium 2 chloride is there, everything is happening there. So that is why the damage also will be there, and hypoxic injury due to its high metabolic demands. And naturally when the work is more, the requirement will be more. S1 is having high oxygen demand because S1 is secreting in the PCT, S1 is having high oxygen demand. In the loop of Henle also, the thick segment is having high work, so high oxygen demand, high demand and low supply. This mismatch between high metabolic work and limited oxygen makes this segment a common site for injury, especially in conditions that reduce blood flow to the kidney. Everything starts, there is always a coordination between brain, heart and kidney. Brain is located, heart is located and kidney is located. Whenever the blood supply reaches to the kidney is decreased, then immediately the all the physiological homeostasis gets disrupted. Kidney starts activation of renin angiotensin aldosterone system, brain releases epinephrine, heart is made to pump more. So many changes happens inside the body. Now let us go to the next part, distal tubule and the collecting duct. So the macula densa, a specialized group of cells located at the end of the thick ascending limb, plays a critical role in regulating the glomerular filtration rate through a mechanism known as tubuloglomerular feedback. So distal tubules and collecting ducts. So we call it as maculodensa tubuloglomerular feedback (TGF), which prevents loss of fluids or electrolytes due to impaired tubular reabsorption. Because the DCT and CT is the last part of the body where every effort is made to see that what is the osmolarity, what is the consumption of water by a patient, what is the sodium concentration, potassium concentration, chloride concentration. Every effort is done by DCT and CT to see that nothing important for the body goes outside of the body. So that is why increase in solid delivery or concentration at macula densa, distal tubular cells contain a high mitochondria but lack a well-developed brush border. So, only thing that happens at the CT and especially at the CT, the collecting tubule, is the potassium secretion, sodium reabsorption, hydrogen secretion, that is by the active transport. So even your role of aldosterone comes here in the CT, and also ADH synthesis also arrives at this particular part. Then fine tuning. So someone is speaking, I guess.
చెప్పకుండా అవును అక్క నువ్వు
There
చెప్పిన
are someone to mute. Okay.
Sorry for the interruption, sir. You can continue.
Yeah. So ultimately, if you see the filtrate in the glomerular filtration, you have everything that is required for the body. But ultimately, if you see the filtrate that is in the collecting tubule, you have been taken, the filtrate is concentrated, reabsorbed, and you have only substance that is not useful to the body. So the early distal tubule is responsible for reabsorbing the remaining sodium, potassium, and chloride ions. The late distal tubules and the collecting ducts are involved in the fine tuning of urinary volume and the composition, and ultimately, a urine is formed without having ingredients that are essential for the body. And then we will just see, I told you at the last, the ADH also plays a role. So water permeability in these final segments is largely influenced by ADH. Chemicals that interfere with ADH signaling or increase medullary blood flow can impair the kidney's concentrating ability. So blockage of ADH signaling pathways, alterations in medullary blood flow, or direct damage to CT, that is the collecting duct, may have the loss of more amount of the important ingredients that are required by the body. Now I just want to see you for 2 to 3 minutes. All the things what I have just explained to you in an animation form. So I'll just put it for you. Just see whether you can, make the things more simple. Is it audible? Is it
No,
audible?
sir.
yes no cannot.
Video is not audible, right?
It is visible, but audio is not available, sir.
1 second. Yeah. Now.
Yes, now it
The
is audible.
average adult has about 4.5 to 5.5 liters of blood inside their body. Blood is carried into the kidneys by the renal artery. The healthy kidney constantly cleaning about half a cup of blood every minute and getting rid of waste material, toxins, and excess water in the bloodstream. In the kidney, there are millions of tiny blood filters called nephrons. Nephrons are so small, you can see them only with a high-powered microscope. Each nephron is made up of a very small filter called a glomerulus, which is attached to a tubule. As blood passes through the nephron, fluid and waste products are filtered out into the ureters. The ureters are narrow tubes that carry urine from the kidneys to the bladder. Muscles in the ureter walls continually tighten and relax, forcing urine downward, away from the kidneys, not allowing them to back up or stand still. The urine then enters the bladder. The bladder is about the size and shape of a pear when empty. The bladder's walls relax and expand to store urine, allowing urination to be controlled. The normal capacity of the bladder is 400 to 600 milliliters. The bladder has a direct line of communication with the brain. It is full of receptors. An invisible fill line that tells your brain how full your bladder is. When your bladder is full, the nerves alert the person that it is time to urinate. Then the brain signals the bladder muscles to tighten, which squeezes urine out of the bladder. At the same time, the brain signals the sphincter muscles to relax, to let urine exit the bladder through the urethra. Urine is about 95% water and 5% waste products, including urea, creatine, ammonia, and uric acid. The urethral sphincters, either male or female, are two muscular structures that regulate the outflow of urine and help keep urine from leaking by closing tightly.
So we now in the first phase we came to understand that how different organelles or the parts of the nephron are working together to produce a urine that is free of the important ingredients that is required for the body. Now let us see slowly that what is the pathophysiologic response of the kidney and how these pathophysiological responses are going to study. Now please remember, before we go into these pathophysiologic responses of the kidney, the most easiest, somebody is on, I guess.
Um, I request the participants to please go on mute.
Yeah.
Yes, sir, you can continue with the session.
Yeah, so before we enter into the pathology and pathophysiologic responses of the kidney, let us just recollect ourselves that we do a simple test called urine analysis, where we check the urine volume, osmolality, pH, and urinary composition, that is electrolytes, glucose, and protein. What is that? That gives an indication that if there is increased urine volume and decreased specific gravity, that is osmolality, suggest impairment in the concentration ability, possibly via a defect in ADH synthesis, release, and or action. If there is a glucosuria, may reflect that I told you a PT reabsorption of sugars, but it can also be secondary to hyperglycemia like diabetes. Excretion of high molecular protein like albumin suggests glomerular damage, or excretion of low molecular protein like beta 2 microglobulin suggests that there is a PT, that is the proximal convoluted tubule injury, or excretion of enzymes localized in the brush border like ALP, GGT, reflex brush border damage, excretion of other enzymes like LDH, reflects more generalized cell damage, and any kind of sudden increase of ALP, GGT, and LDH may result in early loss of available enzymes, and overall you can say that something is wrong is going on with different segments of the kidney. And by additionally, in addition to the urine analysis, basic urine analysis, the serum chemistry like blood urea, serum creatinine. So increase in serum burn, blood urea nitrogen, and creatinine may be secondary to dehydration or hypovolemia, or protein catabolism because of muscle injury, and other test what we use to assess the renal function is phenol sulfathalin, that is PSP excretion, or P amino hippuric acid excretion, that is the measurement of renal blood flow or glomerular filtration, or the in the preclinical studies usually we go with the histology studies. So let us just see. So basically, we identify the damage in a broad word rather than at the broad organ level as acute kidney injury. So AKI represents a common and often severe manifestation of nephrotoxic damage. Its clinical spectrum can range from a mild elevation in serum creatinine levels to complete anuric renal failure. So, what could be the causes of AKI? It could be a pre-renal causes, intra-renal factors, or post-renal factors. So, I have just classified as a pre-renal changes in blood volume and pressure supply to kidney. So, the potential causes could be a bleeding, fluid loss, burns, and non-steroidal anti-inflammatory drugs. Individually, we will discuss, but now broadly, I am just explaining that intra-renal there may be acute tubular necrosis or glomerular nephritis, recent surgery or nephrotoxic medications, and post-renal. So acute kidney injury post-renal, urinary obstruction anywhere between kidney and tubules, and urethra like kidney stones, pyelonephritis, benign prostatic hyperplasia or swollen lymph nodes. So what mechanisms decreasing the GFR in AKI? There are several mechanisms contribute to a decrease of GFR. I told you 120 ml per minute, but during the acute kidney injury, so there is a renal vasoconstriction. This leads to a reduction in renal blood flow, tubular obstruction, and back leak of glomerular filtrate. So overall, please remember that the major damage of the AKI will result in abrupt decrease in GFR with resulting azotemia. So as a result of which there is a cell to matrix and cell to cell adhesion mediated by integrins and cell adhesion molecules. Uh, I'll be explaining in detail in the next slide. But renal vasoconstriction, tubular obstruction, and back leak of glomerular filtrate. So damage to the epithelial cells and compromise of cell adhesion can create gaps in the tubular lining, allowing filtered fluid to leak back into the interstitium, thereby reducing effective filtration. So we have a high serum BUN, blood urea nitrogen, and creatinine, and you all know that when BUN level goes high, it stimulates the chemoreceptor trigger zone CTZ in the CNS, and the patient starts showing the emesis, severe emesis. So without touch and severe pain in the renal part. So without touching the body of the patient, emesis, uncontrolled to the any antiemetics, and high BUN levels as a pathognomonic clinical sign or a study identification that AKI acute kidney injury has happened. So additional mechanisms reducing the GFR, that is intrarenal vascular damage, inflammation, and glomerular dysfunction. So it could be hemodynamic alterations within kidney or any inflammatory process within the kidney or a glomerular dysfunction within the kidney that causes a reducing the GFR. So that is the primary damage. So what is the prevalence of AKI if you see both the pre-renal, intrarenal and post-renal? So pre-renal accounts for 50 to 60% of the cases, while intrarenal causes 35 to 40% of the cases, that is because of ischemia, reperfusion injury, or direct nephrotoxicity accounts for 90% of the intrarenal AKI. So if you see a kidney from transition from AKI to CKD, that is acute kidney injury to chronic kidney disease. So all because despite of adaptive repair, and then ultimately it goes to maladaptive repair. So mechanisms, models, biomarkers. I have shared a article in the renal physiology 2024 mechanisms, models, and biomarkers. I will share in the group so that you can have an extensive study about how the immune cells inflammation are leading to ultimately the fibrosis in a particular kidney, resulting in chronic kidney disease. What is chronic kidney disease? So healthy kidney, acute injury, chronic disease, and end stage failure. So the progression from AKI to CKD and ultimately end stage renal failure often involves a cascade of secondary pathophysiology process initiated by the initial toxic insult. So long-term damage after AKI, increased protein and albumin excretion, reduced microvessel density. So prolonged exposure to certain chemicals including analgesics, lithium, cyclosporin can directly lead to CKD. What is the compensatory mechanisms taken by the kidney in case of CKD? Initially, compensatory mechanisms in my first slide, I told you that only when toxicant overwhelms the compensatory mechanisms, then the visible clinical signs is exhibited. The organ will start showing the functional loss, and thereby it starts entering into AKI subsequently to end stage. So chronic kidney disease, fewer increase the phosphate excretion, lowers hyperphosphatemia. So hyperphosphatemia as a CKD progresses, the compensatory mechanism also starts to fail, and ultimately there is a phosphate excretion and increased or decreased glomerular pressures. The pressure within the remaining glomeruli increases to compensate, but ultimately what happens? Blood flow is redirected and increased through healthy nephrons to maintain filtration. Whether you take the heart, where if there is any problem with the heart, ultimately the heart enhances the size and the force of contraction is less and the cardiac output is less and the pressure from the brain is very high, and that is through the alpha beta 1 receptor of the sympathetic nervous system. And the GFR, I told you that blood supply is 1200 ml per minute, renal blood supply, that goes down. So renin, angiotensin, aldosterone gets activated. So sympathetic nervous system and the renin, angiotensin, aldosterone system, they put lot of pressure on the heart to see enhance its force of contraction and cardiac output. So already heart is having a problem, it cannot work. So ultimately what it will do is it is increase the size. There we see the cardiomegaly in the X-ray, where you can appreciate that. In the kidney also, rather than a particular segment of the kidney where the damage has taken place, and then immediately what happened, in order to sustain the filtrate and in order to ascertain that the unwanted substances are excreted out, the blood supply is increased to the redirected and increased to healthy nephrons to maintain filtration. But ultimately, if the damage continues or the insult continues, then there will be severe damage to the particular part. So adaptation following the toxic insult. So the kidney has a remarkable ability to compensate for a loss in renal functional mass, compensatory hypertrophy. There I use the word cardiomegaly. Here you have a compensatory hypertrophy. So following a nephron loss, the GFR of a remnant nephrons increases 40 to 60% after unilateral nephrectomy. So accompanied by proportionate increase in tubular reabsorption. Everything it will does. There also the size of the heart increases. But again, when you administer, when you start treating a case of the cardiomegaly case, before it enters into congestive heart failure, whether you start with angiotensin converting enzyme inhibitors or the cardiac glycosides or the diuretics, the risk lies when the cardiomegaly comes back. So after the hypertrophy, whenever the heart is entering into normal size, that reversal will have is very risky. Here also the compensatory hypertrophy will be there, cellular response is there, blood supply is directed, but ultimately the injured cells and have to undergo apoptosis or oncosis. So regeneration by dedifferentiation, regeneration by scattered tubular cells, either STCs. So ultimately the growth factors like epidermal growth factor, hepatocyte growth factor, or the IGF-1 accelerate renal repair after injury. But ultimately, if the toxicant insult is very high, these adaptation will not provide any relief to the kidney. So what are the maladaptive consequences? Over time, these adaptive changes can become maladaptive, leading to progressive renal decline. So mechanical damage, glomerular sclerosis, scarring of the glomeruli, tubular atrophy, wasting away of the kidney tubules, interstitial fibrosis. We call it as the scarring of the kidney tissue. So what is the functional and structural criteria for kidney diseases? So I have just kept a table where criteria: acute kidney injury, acute kidney disease, chronic kidney disease, and non-kidney disease. Within 7 days, the functional criteria: increase in serum creatinine. In acute condition, GFR is less than 60 ml per minute, and in the oliguria, increase in serum. So in the chronic disease, it goes less than 60 ml per minute. In non-kidney disease, it never goes less than 60 ml per minute. This is just a population about the extent of the chronic disease prevalence in India. For your idea, those who are working in drug development or preclinical studies, a systemic review and meta-analysis from community-based representative evidence between last 10 years, where a meta-analysis has been done. And then you can see in the eastern zone, we have a CKD population of 8.6%. Northern zone, you have 7.2%. Western zone, you have 15.3% because of the climatic conditions. And then the southern zone, you have 14.8% of the CKD condition. That itself shows you that the how the environmental temperature, the location of the particular place, the food habit, and the dietary lifestyle of the people will make the kidney performance from a healthy kidney into a CKD. Now, why, how these damages occurs? What are the biochemical mechanisms of renal cell injury? Renal cell injury frequently culminates in cell death, predominantly through distinct process. One is oncosis, also known as necrosis or apoptosis. So I told you that there is a damage to a particular part of the nephron, but subsequently the blood supply is diverted to other nephrons. So the nephrons either they grow, multiply, but when they multiply, the multiplied cells during the course of the recovery have to be given a signal for the death. So either it is cell induced death, as you remember that you need to read a chapter from Roberts, molecular basis of pathology, authored by Vijay Kumar, where there is a cell damage and cell death. Very good chapter is there. I will share in the group to the moderator after the class. That will give you a very beautiful presentation about how a cell dies and how the MTP, mitochondrial transition pore, inside the mitochondrial membrane will give a signal for the release of the calcium and subsequent chain reactions for the cell to die on its own. So apoptosis is the highly regulated and controlled form of programmed cell death that typically affects individual cells, whereas oncosis, in contrast to apoptosis, it typically affects contiguous group of cells and is characterized by organelle swelling, an increase in cell volume, eventual cell rupture, and complete damage to a particular part. So whenever the apoptosis happens, the recovery is very good, but if it enters into the oncosis beyond the capacity of the regeneration happens, then definitely it is a huge damage. So focus on apoptosis is highly regulated. Until unless the cell is in apoptosis, no worries. So cellular shrinkage, maintenance of organelle integrity, orderly fragmentation, efficient phagocytosis, and no inflammatory response. Everything will be fine. Growth factors implicated also will be taking care in the regeneration. So we have a fair chance for the renal part to get repair. So mediators, caspases, I don't want to go much into this particular part. I told you that you need to compulsorily read that particular chapter which I am going to share about the apoptosis and the necrosis. The pathological mode is same, is not much difference. So caspases, a family of cysteine proteases, are central mediators of the apoptotic pathway. Lower concentrations of toxicants may preferably induce apoptosis. So focus on oncosis. So you have a organelle swelling, increase in cell volume, eventual cell rupture, release of intracellular contents, and significant inflammatory response. So maybe the toxicopathologist will immediately give you a report on the histology slides that different segments of the cell membrane belonging to a nephron, renal tissue is damaged. So this we will really appreciate in preclinical studies. In most of the clinical studies, where if we get any kind of abnormal lesions on the histological slides, especially in the preclinical studies of rats, mice, or any drug development or safety studies, then it is really a cause of concern. Again, we need to sit and check the kinetics, then toxicokinetics, everything. Then mediators of oncosis, again, it is same members of receptor interacting protein kinase, most important mediators of oncotic cell death. So signaling kinases, either you go with protein kinase C, the largest family present inside the different organs or the MAP kinases, and also the AKT and phosphatol-inositol 3
Can you
kinases.
go to the back slide?
Yes.
Thank you.
We will discuss at the end of the slide. We will discuss at the end, right? There is a question and answer session. Slide wise, we will discuss. Would that be okay?
Yeah. Thank you so much. Yeah.
AKT and P, protein kinase B, and the basic signaling kinases that are responsible for mediating both renal cell death and recovery processes following the toxicant induced injury. So again, the mediators of toxicity, how the despite of the insult that is done to different segments, how the kidney is trying to protect itself, adaptation following an insult, that is heat shock response, that is the major proteins that are responsible for a vital role in cellular defense mechanisms. They act as a protective mechanism against various forms of cellular stress and toxicity, and are crucial for cellular recovery. So quickly, just how the HSPs are critical for the protection of the cell from the toxic insult, either proper protein folding or protein translocation, repair and degrade damaged proteins, and prevent protein aggregations. So basically, by ascertaining that there is the damage, that insult that has happened is not wide and varied, and thereby the proper protein folding happens. So HSP inductions by the nephrotoxicants, the induction of HSPs has been observed following exposure to range of nephrotoxicants, demonstrating their role in the cellular stress response. So example include gentamicin, haloalkaline cysteine conjugates, mercury chloride. We'll discuss a little bit more on each and individual in subsequent slides. So the slide mention is only that if the HSPs are being observed, so definitely there is an injury, and a particular part of the nephron is trying to recover from that insult or injury. So the kidney's vulnerability to toxic responses. So I told you that the because of the exposure of the blood supply and also the basic functional capacity of the kidney, so inherent physiological characters contribute significantly to its susceptibility to drug induced injury. So these include its exceptionally high blood flow, which constitutes, so same thing I just wanted to tell you that because of its physiological location and also its physiological role, because it is the last part of the body where it needs to do lot of filtrate, so naturally exposure will be very high. So what will be the damage by these organs? Now we'll see what is the damage that is happening and what is the mechanism of the damage to these different parts of the nephron. So the diverse nature of these mechanisms necessitates robust preclinical and clinical testing strategies to identify nephrotoxic risk at early stage. Of course, in the last 10 slides, I will take up the regulatory part, but basically how the nephrotoxicity is happening was my contention to be submitted here. The direct cellular toxicity, certain drugs such as cisplatin and aminoglycosides, especially the gentamicin, accumulate within the PCT. This accumulation often occurs via specific transporters, including organic anionic transporters, leading to cellular injury. And then mitochondrial dysfunction, compounds like tenofovir can disrupt the mitochondrial function by interfering with mitochondrial DNA polymerase, or as usual the oxidative phosphorylation, and ultimately there will be a ATP depletion, ultimately leading to cell death. And your oxidative stress, where we consider as the major role in the damage, that is the reactive oxygen species, and also the decreasing, either you take singlet oxygen or free radicals, or there is a decrease in catalase, superoxide dismutase, glutathione peroxidase, glutathione reductase. So whenever these enzymes reduce in the given condition, so the radicals react to oxygen enhances, and thereby they damages. Subsequently, the exposure to the NSAIDs can also induce oxidative stress. So this manifests as a lipid peroxidation, and then depletion of cellular antioxidants contributing to kidney damage. So Additional mechanisms, of course, ferroptosis, crystal nephropathy, and vascular effects. This is a recently identified iron-dependent form of programmed cell death. While its role in drug-induced AKI is increasingly recognized, further research is needed to fully elucidate its involvement in specific drug-induced injuries and crystal nephropathy and vascular effects. Some drugs like acyclovir can precipitate within the renal tubules, forming crystals that obstruct flow and cause injuries, especially ischemic injury. So I told you that ultimately, whether you consider each nephron as a cell, and then if you consider what are the reasons for the death of a cell or damage to the cell, so the damage, most common damage method is by generation of free radicals, which rupture the cell membrane, or the direct cellular toxicity based upon the ionic uh, changes that happens on the surface of the cell membrane, or the mitochondrial dysfunction, major role that produces the damage. Now let us just see that what are the specific nephrotoxicants and how these nephrotoxicants are damaging the different kidneys. So susceptibility of the kidney to toxic injury. So incidence. So nephrotoxicity is recognized liability of classes of drugs such as antibiotics. Usually we say aminoglycoside among with the gentamicin. There is a review article on gentamicin. I'll just share after this class the review article on the entire gentamicin and how it is producing the renal damage, followed by the ACE, angiotensin converting enzyme inhibitors. So they are also one of the, even though we use as a first line of agents for cardiac related, but they are also producing nephrotoxicity. Then you have a glafinin, an analgesic. Then you have your NSAIDs, non-steroidal anti-inflammatory drugs, and then you have the diagnostic markers like radio contrast media that is producing the damage to the kidney. So you can say that the reasons for kidney susceptibility by these organs, it varies from the damage to damage. So heavy metals, potent renal toxicants. So heavy metals represent one of the most dangerous class of nephrotoxicants, with mercury and cadmium being particularly damaging to kidney. The kidneys serve as a primary filtration sites for these metals. Most of the question papers of the ABT, they have a question, at least one or two question pertaining to mercury and cadmium, because they are the heavy metals. They cannot be, there is no established mechanism in the world to remove any heavy metal from the environment, or any mechanism to remove. So their entry is by different sources, especially the cadmium in humans, and also the mercury to some extent. We have minimized the mercury, but still you get lot of questions on mercury and cadmium. So in the nephrotoxic, mercury and cadmium are the primary. The kidney serve as a primary filtration for these metals, making them especially vulnerable to toxic accumulation. And then exposure occurs through contaminated water, foods, industrial process, and dental materials. So these metals disrupt the cellular function, damage mitochondria, and trigger oxidative stress, ultimately leading to tubular necrosis. I'll just go through a little bit more in the mercury. And mercury is different forms. You have toxicokinetic profiles, like elemental mercury readily crosses the blood-brain barrier and placenta before oxidized to the mercury, while inorganic mercury compounds directly damage tissue upon filtration. So whether you take elemental mercury, whether you take inorganic mercury, or methyl mercury predominantly from the seafood consumption, usually questions are very common from mercury as well as the cadmium. So the toxic stem largely from its exceptional affinity for sulfidyl groups in cellular proteins, disrupting critical enzymatic functions and causing severe mitochondrial dysfunction. So little bit, if you see the mercury in the environment, either if you take elemental mercury in the form of metallic mercury or vapor, mercury salts, either mercury chloride or mercury oxide, organomercury compounds like ethyl mercury, methyl or propyl or dimethyl, or aryl forms of mercury such as phenyl mercuric acetate. So damage, days to permanent damage, and mercury is going concern in the environment. Massive work has been done to eliminate mercurial compounds, and nowadays it has been reduced. But earlier, this is an, you can say, that historical heavy metal. But now the whole focus is shifting towards the cadmium. So I just mentioned different sources of mercury, whether it is a thermometers, paints, barometers, electrical equipments, manufactured formulations, and very commonly asked question is Minamata Bay as well as Nagata disease. Minamata disease and Nagata disease, everyone knows that the methyl mercury and to a lesser extent ethyl mercury are primary concerns with regard to environmental forms of mercury. And Japan was the leader in the electronics in 1956 to 65, and there was release of the mercurial compounds into the water, nearby water areas, and Nagata and Minamata disease, where the fish has accumulated the mercury compound and eaten by the humans, and then it has resulted in massive outbreak of conditions. So this is also very common. So elemental mercury, orally non-toxic, inorganic, absorb 10% from the GI tract, organic, absorb 90% from the GI tract, but you have inorganic mercury is eliminated primarily by urine. That is why inorganic form of mercury is highly renal toxic compared to organic and elemental mercury. Most of the questions will be asked only in this form, or there no question. I think I can say that no question in the ABT will be asked as direct question. Most of the questions will be related with the fundamentals or the foundation linked to the that particular metal or that particular chemical. So out of the mercury, inorganic, because eliminated primarily by urine, that is why it is one of the major damage. So sulfhydryl groups of enzymes and other proteins are affected, and other as a result of which, mercury readily forms covalent bonds with sulfur, replaces hydrogen. So you get a negative radical, and ultimately the damage to the kidney. So inorganic form I am focusing. So kidney damages, PCT breast border, and then PCT epithelial cell damage, ultimately anuria, no reabsorption, eliminated blood creatinine and blood urea nitrogen. So clinical signs, not much, but important point you need to remember is a word called GET, gingivitis, and then tingling, and loss of sensation in the abnormal spontaneous sensation, visual changes, and severe eliminated bun causes nausea and vomiting. So kidney is the target organ of inorganic mercury. So broadly, if you need to remember, so mitochondrial dysfunction, oxidative stress, calcium dysregulation, and immunological response. Then cadmium's impact, I told you, we are anticipating a lot of questions on the cadmium. So chronic exposure to cadmium, particularly in non-smokers, primarily impacts the kidney, leading to renal dysfunction. So primary target, kidney is the main organ affected by chronic cadmium exposures. So halogenated hydrocarbons. So the class of chemicals includes compounds like chloroform, tetrafluoroethylene, which can cause significant damage to the kidney through metabolic activation and direct toxicity. Then chloroform nephrotoxicity, metabolic activation by renal cytochrome P450 enzymes, reactive intermediates, especially phosgene, is generated, and this phosgene is producing actual damage. So I can say the kind of the ability of the nephron to excrete the chloroform, resulting in the phosgene, and phosgene is highly reactive, damaging the renal tissue. Tetrafluoroethylene and its metabolites, exposure to TFE and its metabolites cause renal tubular necrosis. The mitochondria appear to be a primary target of TFE, with a reduction in state 3 respiration preceding cellular demise. So oxidative stress also contributes to the nephrotoxic effects of the tetrafluoroethylenes. So ochratoxin is a very established compared to aflatoxin, having a severe damage to the different segments of the kidney. So you can say a specific nephrotoxic ochratoxin compared to fumonisin or aflatoxin B1. So now slowly we will move to the drug-induced nephrotoxicity. So mechanisms, regulations, and future directions. Then we will discuss about the different role. So the kidney's pivotal role in drug metabolism and excretion renders it highly susceptible to drug-induced toxicity, commonly known as nephrotoxicity. This adverse effect significantly contributes to AKI. In clinical settings, approximately 19 to 26% of the incidents. So the drug is intended, might be intended for any other purpose, but unfortunately during its metabolism, if it damages any segment of the nephron, then we need to sit and recheck everything, and then whether it is only an AKI, whether it is a regenerative, to what extent the damage, so many toxicological assessments needs to be done. So nephrotoxicity is a substantial factor in drug attrition during pharmaceutical development, with up to 20% of the drug candidates failing due to kidney related safety concerns. Okay, so we are in the last lap of our today's discussion. The last lap have been divided into two parts. One is how the drug is acting as a nephrotoxicant, and subsequently will end up with the drug development and what exactly the regulatory aspect. So the therapeutic agents as nephrotoxicants, most commonly used medications, can have adverse effects on the kidneys, leading to a range of toxicities from acute injury to chronic disease. Understanding these risks is crucial for the patient safety. So acetaminophen and NSAIDs. So acetaminophen, it acts on S1 and S2 segments for the PT, as well as it also acts on cytochrome P2E1 and also on the glutathione conjugates and non-steroidal anti-inflammatory drugs. It acts on like aspirin, ibuprofen, naproxen, indomethacin. They act through inhibition of prostaglandin synthesis. So either in acute renal failure, chronic consumption of NSAIDs produces analgesic nephropathy, we call it as. So papillary necrosis with chronic interstitial nephrosis, nephritis, rare interstitial nephritis, which is characterized by diffuse interstitial edema, that is increased serum creatinine and proteinuria, which are reversible except the analgesic nephropathy, very commonly asked word in most of the examinations. And we'll also, after this session, we'll share a small synopsis of 10 to 12 pages, where all the topics what we have discussed today will be kept in a readable form to the group, and then they will be sharing you to all the interested persons. Aminoglycosides, nephrotoxicity is a well-recognized side effect. These drugs are filtered by glomeruli, bind to proximal tubules, undergo pinocytosis, and accumulate within lysosomes, leading to cellular damage. We have a very good review articles of gentamicin, I told you in between, that also will be shared, where you can just request to go through. Very elaborately written review article is available. Amphotericin B, so renal dysfunction dependent on cumulative dose and is due to both hemodynamic and tubular effects. Amphotericin B binds to cholesterol in the plasma membrane and form aqueous pores. So increased proton permeability, increased proton excretion, that is hypokalemia, and renal tubular acidosis impairs functional integrity of the glomerulus and of the PCT and DC portions of the nephrons. Immunosuppressants and chemotherapy like cyclosporine and also the cisplatin, very commonly used in the cancer chemotherapies. So cyclosporin A, immunosuppressive agent that act by selective inhibition of T cell activation. So it produces acute reversible renal dysfunction. It decreases the renal blood flow and also decreases the glomerular filtration rate. So acute vasculopathy, chronic nephropathy with long-term treatment with interstitial fibrosis. And then cisplatin is responsible for the majority of the cisplatin excretion, that is kidney, and is a primary site of accumulation. So acute and chronic renal failure, renal magnesium wasting and polyuria. So acute renal failure characterized by renal blood flow decrease, decreased GFR, and also beta 2 microglobinuria and inappropriate loss of magnesium. Primary target is the proximal tubule S3 segment in humans. S1 and S2 segments, distal tubules and collecting ducts may also affected. It does not affect the glomerulus. One of the question that was asked in the ABT was that cisplatin does not affect the which segment of the nephron. And then the diagnostic markers, most of the time we use the radio contrast agents like ditriazide derivatives. So iodinated contrast media used in imaging procedures can be nephrotoxic, particularly in patients with pre-existing renal impairment, diabetes or heart failure. Newer non-ionic contrast agents have lower osmolality and are generally associated with reduced nephrotoxicity. So hemodynamic alterations, that is the toxicity is attributed to both hemodynamic alterations, vasoconstriction and direct PCT, proximal tubular injury and direct tubular injury through ROS. So assessment of the renal function, evaluating the impact of nephrotoxicants require accurate assessment of kidney function. Several methods and biomarkers are used to measure the GFR rate and detect renal injury. In our day-to-day method, we go for urine examination, specific gravity, culture, glucose, amino acids, inulin clearance, indirect GFR indicators, that is burn and serum creatinine. So burn and serum creatinine are commonly measured indirect indicators. In most of the preclinical studies, we go with this. Decrease in GFR, significant drop in GFR is required before burn and creatinine levels are rise noticeably, so making them relatively insensitive markers. But extrarenal factors, elevated levels can also be influenced by non-renal. But even then, we always attribute it because of these two things. Then cystatin C, a more sensitive marker, and endogenous protein with a molecular weight of 13 daltons is considered more reliable. But it all depends upon the type of drug development you are looking for. So we have just kept a slide of environmental toxicants and the mechanisms by which they are going to produce the response, like bisphenol A, acrylamide, then DEHP. Of course, these are all different pathways, which is we are not going into so many pathways. Each pathway is having a different role in the performance of the particular part of the nephron signaling pathways. But overall, broadly, just for you to produce show you that how these triazole derivatives are producing the response was the importance of this slide. So mechanism of medication induced nephrotoxicity. So afferent arterial vasoconstriction is produced by these drugs. Efferent arterial vasodilation is produced by these drugs, and interstitial nephritis is produced by these drugs. Crystal nephropathy is produced. So drug wise, I have just kept a slide where glomerular injury, interstitial nephritis, crystal nephropathy, acute tubular necrosis, and afferent and efferent arterial effect in terms of cortex and medulla. I have just shared a slide. So coming to the chemicals, pesticides, paraquat has produced PTC dysfunction, glyphosate, vomiting, diarrhea, fluid loss, hypovolemic shock. Then you have DBCP DNA damage. Then you have acute kidney injury. All these are producing the acute kidney injury, including the ethylene glycol, where most of the countries it has been banned. So I have just gave you examples of the pesticides and other chemicals that are identified as producing damage to different segments of the nephron. DBCP is 1,2-dibromo 3-chloropropane. The abbreviations have been given under the slide. So, summary, heavy metals, mercury, cadmium, those who are preparing for the exam, halogenated hydrocarbons, chloroform and TFE, and natural toxins, mycotoxins, especially okra, therapeutic agents, NSAIDs, aminoglycosides, cisplatin, cyclosporin A, and imaging agents, your ionic compounds, dry triazide derivatives. So I just kept everything in one slide here. Kidney toxicity associated with drugs of abuse and their clinical manifestation. Either you go with the amphetamines, or especially these are cocaines, MDMA metabolite. This is only just for information, but only because most of these drugs are taken as a drug addiction, I cannot say that it is a uh, voluntary or involuntary damage that is being happening inside the body. Then vigilance in renal health. Now slowly next 5 minutes I'll cover about the regulatory. Understanding the mechanisms of specific nephrotoxins is vital for prevention, diagnosis and management of kidney disease. Continued research and careful monitoring of renal function are essential to mitigate the risk posed by these diverse compounds. So you have regulatory guidelines for nephrotoxicity assessment by US FDA, OECD and EMA. They provide harmonized guidelines for evaluating the kidney safety in pharmaceutical development with a primary focus on human health rather than environmental risk unless specifically mandated. EMA has become very rigid from September 2024. So for most of the drugs, ER environmental risk assessment is mandatory. You have to justify for each and every drug if you are authorizing whether it is generic, whether it is innovator, whether it is anything after September 2024, you need to justify. They have given a lot of significant importance for the environment, and also you need to justify by all means, including impurities, and in this case, especially the kidney safety. So guidelines, US FDA guidance for industry 2000, the detailed protocols of nephrotoxicity assessment, whether you do non-clinical studies, whether you do biomarkers, or whether you go for renal impairment studies. So you have a specific designed markers where you need to justify that there is no untoward increase in the serum markers, urine analysis, assessment of organ weight changes, and detailed histopathological examination of kidney is a mandatory in the repeat dose toxicity studies, whether you conduct for 28 day or 90 days. OECD, whether you do repeat dose toxicity study, whether you need to follow GLP and environmental considerations, especially in terms of the aquatic systems. What is that is entering in the environment, and then as per the aquatic system OECD guidelines, you need to ascertain that no much damage is being done because of the discovery of your particular chemical. So EMA guideline on evaluation of medicinal products in patients with impaired renal function and ICHS5 R3 generally aligned with US FDA requirements. Same thing, non-clinical testing, pharmacokinetic modeling, and environmental risk assessment. So most of the time, if you have anything a problem with the histopathology, organ weight, or the serum markers, or the urine analysis issue of the preclinical studies, then definitely we need to sit and ascertain that where exactly and why exactly the things are happening, and whether is it because of the adjuvant, is it because of the chemical preservative, so we need, or impurity. For everything we need to justify. And the latest problem is, even if you are trying to justify with British pharmacopoeia in the EMA, they are not accepting. That is the biggest task. It is being coming. You need to justify as such as a whole, based on the data that is being available with you, either in terms of impurity or in terms of the main drug product. Current practices, non-clinical approaches, animal studies, in silico tools, in vitro models, and adverse outcome pathways. So the OECD supported adverse outcome framework mechanically maps the progression from molecular initiating event to an adverse outcome, that is mitochondrial toxicity leading to tubular injury, So a deeper understanding of toxic mechanisms and support the development of animal sparing testing strategies. So the articles where I feel that you need to read, and whatever the review articles are useful, I'll be sharing with the moderator after the talk, and you can just collect from there in the group or for easy access, and you can just go through the latest in vitro models, in silico tools, and how we can uh, minimize the significant impact. So current practices, clinical approaches, biomarker monitoring, pharmacokinetic studies, and translational challenges, that is significant species specific differences in drug transporter expression. That is the reason why most of the time the EMA is not accepting even BABE studies of any drugs that we are doing in India, especially if it is recently released innovator products. So they are insisting to do the study in European countries. So industry insights, a 2020 survey conducted by Predictive Safety Testing Consortium revealed 65% of the companies reported drug attrition due to nephrotoxicity, with small molecules being the primary culprits. That itself shows that how tough it is to come up with the drug without damaging the kidney. So common de-risking strategies, early stage screening, biomarker monitoring, and PK modeling, we try to justify. And recent advances and collaborative opportunities, you have a kidney organoids, you have senolytic therapies, and then you have a novel biomarkers, and the role of AI. Again, EMA's 2024 paper on the use of AI supports the application in the GLP and collaborative platforms like predictive safety testing. So challenges and gaps, predictive models, biomarker validation, and mechanistic gaps. And this is regulatory and ethical challenges. So most of the time, the regulatory harmonization is what required along with the 3R compliance, that is replacement, reduction, and refinement. So both the regulatory body as well as the companies, they are moving towards more in silico, in vitro, and then in vivo models. Uh, and we are anticipating more organoids, and most of the time we are also trying to bring a harmonization between the EMA and US FDA, because for one product, same company, US FDA has accepted BP, EMA is not accepted. The same, everything is same, but EMA has rejected, US FDA has accepted, creating so much of burden on the uh, developer. So a team is working to create that the common harmonization can be achieved. So for industry, these are all general articles that are available to overcome the challenges and advance the field of nephrotoxicity assessment. These are the different articles. So conclusion, the nephrotoxicity remains a significant hurdle in drug development, contributing to both the drug attrition and potential safety risks. So regulatory frameworks established by US FDA, OECD, EMA provide robust guidelines uh, for assessing kidney safety, emphasizing the importance of repeat dose studies, use of sensitive biomarkers, and comprehensive pharmacokinetic modeling. So the path forward, that is ongoing challenges relating to relevance of in vitro models, in silico developments, and so many things. So these are the different references we'll be sharing with your team. Thank you for your patient hearing.